We all know about the pathology in CP, that it starts off with spasticity and eventually leading to muscle contracture, then it impacts the joint, causing joint subluxation and deformities. So torsion, instability, and eventually subluxation. So at each level, there's a problem, starting from the spine, hip, knee, the torsion as well as the feet. Now already we know that the GMFCS pattern gets established by around age 6. So whatever pattern you get around age 6 or 7 in a child, that more or less stays more stable. So if you, depending on what time you intervene, that is also very important. Now why do you have to study gait patterns in CP? One is to understand the type of impairment. Also you want to plan the management in the child, and also our goal is to make not only to make the child walk better, but also to make sure that his energy consumption is less. Now for that we must understand what is normal gait. Now normal gait goes through a phase of stance and swing, and there are definite phases of gait which we can now evaluate very detailed in the gait lab. As far as the cause of the deformity is concerned, is that you have spasticity, you have dyskinesia, and you have mixed tone. Now every child may not be purely spastic. They could have a mixed component as well, and that may also alter the gait pattern. Another thing is the topography. As an exam, from the exam point of view, you should know what is hemiplegia, what is diaplegia, what is triplegia, and what is monoplegia, it depending on the level of involvement of the child. And there are many differences in the CP gait and the normal gait, and you've seen that in the evaluation, right from the foot contact, the knee movements, the hip control, the symmetry, the energy use. All that is very important, and one can evaluate in detail. Now there are certain gait patterns which are classically seen in diplegic children, and the most common type of CP we see is the periventricular leukomalacia, and this is characterized by pure spasticity with stiffness and altered limb pattern. So you see a child, somebody like this coming to the gait lab, walking with the bent knee, bent hips, you would classify them as diplegic, but the patterns are pretty much established. So there are 5 classical patterns which are seen in CP diplegia, and this has been well published. So you get a true equinus, you have a jump gait, apparent equinus, crouch gait, and then asymmetry. Now we'll just go through each one of them. Now what is a true equinus? This is a child who walks on his toes. The ankle is plantar flexed throughout the gait cycle in stance. Hips and knees extended. The foot falls flat, and the knee goes into recavatum. So this child has got a pure equinus deformity, which is a true equinus. Now this child who comes like walking the lab like this. Now this, of course, when you are examining in a clinic, you may take a video in the clinic, and you may at least get a rough idea what this pattern is like. So this child has got a pure equinus gait. He's a smaller child, and we know that from examination only this calf muscles are tight. Now there's a whole spectrum of toe walkers. As they grow older, some of the children may present at 20 months, some may present at 7 years, and some may present even later. But all these children are different. Some of them, so this child is a physiological toe walker. This is a diplegic child. This is diplegia, and this child has ADHD. So again, toe walking itself is not a diagnosis. Toe walking has to be ascertained in terms of the age of the child and also the physical examination. Now also you get toe walking in a condition called hereditary spastic paraparesis. This was an 11-year-old child who had difficulty in walking. He presented late, around 4 or 5 years of age. Before that he was completely normal, and yet progressive increase in calf tightness, and his mental status, his upper limb was completely normal. And one should not mistake this with cerebral palsy. This is a hereditary spastic paraparesis, is a genetic defect. Similarly, a child comes walking like this in the clinic. She actually had Guillain-Barré syndrome and was walking with a stiff gait. So there are different patterns. They may not all be CP. So you should be also careful of CP mimickers. Somebody comes with abnormal gait, of course you go through the entire history. Now this is a jump gait. Now between the jump gait difference and the equinus gait is there is the hip and knees in flexion. There's an anterior pelvic tilt and increased lumbar lordosis, so that the child can stay upright. So often they have a stiff knee as well because the rectus is tight, and they may have overactive rectus femoris. So you can see the child actually walking with a jump pattern of gait. And this can again be seen in an older child. You may have different patterns. So this child is a disconnected child, and see how he walks. Again a jump gait pattern, but much older child. And this child is again older, 16 years old, jump gait pattern, hip and knees are flexed, pelvis is tilted anteriorly. So that pattern may persist. if they go untreated, and that is why these children cannot walk long distances because of the energy consumption. Now again you see a child with spastic CP and child with disconnected CP. Now this child who's jittery like this, you can operate on these children, you'll burn your fingers because they've got a disconnected gait, and this is a pure spastic gait. So even from the walking pattern, one can make out what kind of gait disturbance the child has, what kind of tone abnormality this child has got. The third group you see in diplegics is the apparent equinus. So here the ankle has got a normal range of dorsiflexion, but it's the hip and the knee which are excessively flexed throughout the gait cycle. So entire stance phase, the hip and knees are flexed, but the foot drop is there because of the proximal tightness. And of course you have to examine these children. These are just a pattern which you see, but they need detailed evaluation. And finally the common type of gait we see in practice is the crouch gait, where the child is completely flexed at the hip and the knee, and the ankles are excessively dorsiflexed. They are not in plantar flexion. They may look in plantar flexion because of the midfoot break, but there is actually, they are in dorsiflexion. And you can see what happens as the children walk. They are basically needing a lot of effort to walk with the quadriceps power, and there's an excessive dorsiflexion at the calcaneus. So this is classically what we call a crouch gait. Now some other patterns can also coexist. We can also have what is called a scissoring gait along with jump gait. So one should also assess the torsion of the child as well in the coronal profile, and these are because of the tightness of the hamstring and the adductors, and they have a very narrow base of walking. So again one should assess the gait not only in the sagittal plane but also in the coronal plane. And you can also have in-toeing gait. So you can have an equinus with in-toeing. So that can also coexist. So just don't look at the sagittal pattern, but also look at the coronal pattern of the child walking. And this gives you a lot of information about the torsional profile of the legs. Similarly to diplegia, we can also have children with hemiplegia. Now they present with a slightly different gait pattern. Here there's only one side of the body which is involved. Typically the hand and the legs are involved. Very rarely the opposite side may get involved, so they can have also a triplegic child. But here the pattern of walking is slightly different from the diplegics because of the involvement of the pelvic muscles. They actually circumduct when they walk, and they have typically a foot drop. So Winters has classified this pattern again into 4 types, where you have a drop foot gait. That means they've got weak dorsiflexors. You may have a true equinus, just like in the diplegic gait. You may have a true equinus with recavatum, because these children, they lock the knee because of tight gastrocsoleus. And you can have a jump knee pattern. And then type 4 hemiplegics are usually because of the proximal contractures. They get internal rotation as well, in addition to the flexion contracture. So this is a type 1 hemiplegic gait. This girl, if you see as she walks, she got a right side foot drop. And so she doesn't clear the floor very well, but she's got a foot drop in swing. And there's selective dorsiflexor weakness. But there's no calf contracture here. It's pure foot drop gait. Similarly, another child, older child, he's also got a foot drop gait. You can see his right foot, he's unable to clear in swing and it drops down. So this is a type 1 hemiplegic gait. And this is post-surgery also. We've done his surgery. But again you see he goes into recavatum and he still has a drop foot gait. Okay, so it really doesn't help unless you can strengthen the dorsiflexors here. Now this is a type 2 hemiplegic gait, which is a true equinus. You see this girl walking. She's got a pure equinus on the left side. And you can see the classic pattern of circumduction. The hands is also involved. And here there is tight spasticity in the calf muscles. And there's plantar flexion during the gait cycle. And there's excessive hip and knee flexion, hip and knee extension, due to the tight calf. So you can see when she walks, the knee also goes into slight recavatum. Now this is the true equinus jump knee pattern, which is seen in hemiplegics. Now what happens is typically when you have one side involvement, the right side is involved, the left side also goes in the same pattern, because you cannot walk with one leg straight and one leg bent. So that's why some of the children need support to walk. And this child has got tight calf muscles, tight hamstrings, excessive hip flexion. Sorry, I think I just skipped one. Just go back one slide. So this child has got a type 3, which is a stiff knee gait, where there is gastrosoleus tightness with impaired dorsiflexion. And you can see when he walks, he walks with a very stiff knee gait with a tight calf muscle. So there is co-contraction of the hamstring as well as the quadriceps muscles, which is causing this kind of stiff knee pattern. And type 4 is the one where there is problem not only in the sagittal plane but also in the coronal plane. And here they get internal rotation or torsion of the femur, and potentially these children can also have adduction and middle hamstring contracture. So this pattern we see here is a classical type 4 hemiplegic pattern. Sorry for the lightning there, but that's how the video is taken in the clinic. So she's got a type 4 gait pattern where there is internal rotation of the leg as well. The triplegic is rare to see, but you can have also where 3 limbs can be involved. These are rare cases. And sometimes you can see them in the gait lab when this child has got involvement of both the legs and the right hand. And you can see how she's walking. So this is a triplegic gait pattern. Now one must analyze in 3D as well to see which plane is involved more. And that's why the torsional profile, as discussed earlier, is important to see. Now this girl has got a left side involvement more. And you can see how much torsion she's got of the femur on the left side. And then this is also we see them in the gait lab. And you can see the adduction as well as the rotation profile of this child. You can see on the, let me see the video is working or no. So she's actually right side hemiplegic girl. And she also has got limb length discrepancy. That's why there is a lot of pelvic obliquity seen in her. So this can be assessed very well in the gait lab. So you can see the hip adduction, you can see the rotation profile, you can see the tibial torsion here, and you can see the foot progression angle on the right side is external. So again, torsion can impact the foot of the child as well. So when you see the deformity which is in the femur, always assess the knee and the foot as well. So when you have severe plano-valgoid foot, as you can see the knee is in valgus, and when you correct the foot deformity, you should also address the knee here. So you don't only correct the foot here. Now this is a child who walks with tibial external torsion with severe plano-valgoid foot, and you can see his rotation profile. So he's got hip rotation external, he's got internal pelvic rotation, and see this foot progression on the right side. Right is the blue and left is red, and you can see this child walking when he comes back. He's got severe plano-valgoid foot, and that foot deformity actually can be shown as equinus in the gait lab unless you do a foot markers. So sometimes you can get pseudo-equinus because of the plano-valgoid deformity. Lastly is the quadriplegic group. Again, these children usually don't walk, they are not community ambulators, but one should be very careful in these children to look at the hip joint, look at the combined hip abduction angle, because potentially the hip can dislocate. And these children usually have got this kind of wind-swept pattern of lying down, so hips may migrate slowly out, and these ones need intervention to prevent painful subluxation. So we usually intervene when the hip migrates beyond 30-40 degrees. And lastly, also the spine. One should address the spine as well. So sometimes we have to intervene to just improve the seating balance in some of these children. So I'll just quickly go through one case, and then maybe if you have time, what is the time? Chasnal, we have got time for one case? 10 minutes. So I'll just show one case here, and then so this is a 14-year-old child. He's spastic diplegic, type 3 GMFS2, and that's his functional mobility scale. Now he actually was more involved on the right side. He was not a classical diplegic. So this is his let me put in the mode, sorry. So this is his barefoot walking pattern, and this is the coronal walking pattern. You can see that his knees are flexed on both sides, and his feet are plantigrade, and his pelvis is back. And when you look at the and this is how he walks with the AFO. So this is with the AFO. He's got a hinged AFO, and with the AFO also his gait pattern is not changing. It actually gets a bit worse because he goes more into knee flexion. We've done his evaluation, so we've done the knee FFD on the right side is 20 degrees. His popliteal shift is almost 50 degrees on the right side. Left side was only 10 degree FFD, and popliteal shift was 25 degrees. So his main problem was actually in the right hamstring. And then we looked at his ankle range of movement was pretty good. He had good range of ankle motion, so almost 20 degrees of dorsiflexion. So his ankles are not tight. His basically problem was in the knee, and this was his prone rectus test was mildly positive, and I think there's a video there. So you see the rectus test is very mildly positive, And one always debates whether to do a rectus release in some of these children. And this case actually illustrates that. This was his standing pattern in the A4. So also in the A4, he really wasn't standing very well. Now this was his gait report. Now if you look at it very carefully, so he's got, this is working, sorry. Yeah, so if you see here, his pelvis is actually tilted posteriorly. I thought this point is looking at. So his pelvis is tilted posteriorly, but if you look at his knee graphs are way up, and especially on the right side. Right is in blue, and his legs are in dorsiflexion, but his main problem was not in the feet. His main problem was in the knee level, and that was his comparison with the A4. So with the A4 also, it didn't really matter. Only thing was his knee got worse, hips were slightly better on the right side, but it was still mainly the knee. And if you look at his flexion graph in swing, the knee pattern, this is a stiff knee pattern where he doesn't reach peak knee flexion during the swing phase. And so he's got a hamstring tightness, he's also a rectus tightness. Now the prescription was, and he's actually mainly right side was tight, the left side was compensatory. But gait lab will not tell you that. That comes from the evaluation. So our decision was to do his right side. I do a lot of hamstring transfers. So I did a hamstring transfer from the, I removed the hamstring semi-TN gracilis from the attachment and anchored it with the anchor to the distal femur in the hope to improve his hip extension and improve the knee flexion. So this child, and I did Botox to his rectus as well. Now of course this is a kinetics graph. I won't go into much detail. Suffice to say that because he's walking in crouch, in equinus, you see this ankle power generation. This is what you look at, and you look at the ankle and the moment. So because his knees are flexed, you look at the extensor moment, the blue. So there's a lot of cortisol activity because the knees are flexed. So a lot of hamstring, a lot of quads activity. So of course it makes him very, very tired. I mean, there's no time to go into detail of that. But 2D evaluation was done. Then this was the pre-finding. This was the post-finding. So we did a surgery. This is 6 months post-op. So it's a bit early to do gait study post-op. But this was a pre-gait study. And this was a post-gait analysis. So now, I don't know if you can make out from the visual analysis only. But his pelvis got tilted a bit anteriorly. Because we released this hamstring. And this was shown in the graph. And this was with the A4. Pre and post. So this is pre and this is post A4. Okay, so he was much straighter. And this is a 6 month. I'll show you the recent video when he come to the clinic. And this is the pre and post kinematics. So you can see his knees graph has really come down. What was the abnormal image to begin with. But his pelvis is interestingly, his pelvis was tilted backwards, has now become forward. Now that is because I transferred the hamstring, the rectus now became overpowered. So that you see, I have not really improved his clearance in the swing. But he still works better. I gave Botox to his rectus. Now the debate of whether to do a rectus transfer at the same time, we are not doing much rectus surgery nowadays. So I think I should have done the rectus transfer along with the hamstring transfer as well. This was the pre and post with the AFO. And really, again you can see with the dramatic improvement in the knee graph. You see the knee with the AFO completely comes down to normal. And actually interestingly, his rectus improves with the AFO. So there is some effect of the Botox, at the rectus as well. And when I gave him the AFO, so his walking is much better with the AFO. And then recently came to the clinic. So this is 8 months post-op. We've not done his gait study now. So he now walks much straighter. His knees become much more straighter. But he's got a stiff knee gait. But he's happy with his knee position. And I've done only right side surgery, not left side surgery. No, hindsight, I think I should transfer rectus.
If you had no gate graphs, you would have done roughly the same.
I would have not injected rectus then. Now with that, I knew the rectus was tight from the gait study. So I injected rectus. So I think that is what we are learning now. So we don't know the correlation between the Duncan-Ely test and the rectus. So now we are using EMG. Now we just acquired the EMG. So now we are looking at EMG data as well. So we've got a few patients now with EMG recording, and we are comparing with the Duncan-Ely test. So I think it's evolving science. We are still learning. But at least it helped me to understand with the AFO his gait becomes really better. So I locked his AFO.
If you had the same knee flexion with an anterior pelvic tilt, or
So if you had an anti-pelvic tilt to begin with, so I do a transfer. I don't do release. I always transfer. Yeah. I would have done probably rectus release at that time. Yeah, rectus release. I would have done a rectus. Proximal. Proximal rectus, yeah.
Here also, sir, the knee becomes better, but at the cost of
Pelvis, correct. His pelvis has now gone forward. Now, when he came back 8 months later, he's actually walking better. So I think post surgery, no, one should do the evaluation after at least a year. I did at 6 months, but at least one should wait for a year. That's why we are very skeptical to do rectus. Because if you weaken his propelling and he's an ambulatory child. Now I'll just show one interesting case. This is a case of spina bifida. L5S1 spina bifida, right more than left involvement, right knee FFD, plano-valgus foot. I'll just go to it quickly. So this was his gait pattern. So he's walking like this. So he L5S1 and he's got severe plano-valgus foot as well on the right side. This is his, and then I'll quickly go to the graph if you've got. So he also has LLD on the right side, and we did his distal femoral extension osteotomy, and I did his foot surgery as well, and I did contralateral fascial stapling, drill fasciodesis, so that to correct the LLD. He had an LLD of 34 mm, which came down to 17 at the last follow-up. So he was now recently around 1.5. We did a scanogram. This is 2 years post surgery. We did his gait study again. Now he's much straighter now. And with the AFO, he walks better. I'll just show his graph if I have it. This is his 2-year post gait video, and now we're just doing his EMG recording as well. And this is with the AFO. So he's much more straighter. He's gained almost 15 kg weight. So we did his foot surgery as well at the same time, and now his limb length is almost corrected to 1.5. Now this was his graph pattern. This was his graphs. So you see his graph on the right. See, also because of the pelvic obliquity, right pelvic is lower. He had a shortening on the right side, so that pelvic tilt also is seen on the right. But he had severe problem at mainly at the knee. So right is blue. So right was more flexed. The left was compensatory. Left side we didn't do anything. The feet are dorsiflex because his feet are weak. His feet went plano-valgus deformity. But he had an anterior pelvic tilt which stayed almost anterior. So after doing the extension osteotomy, we didn't change his tilt much. His hip flexion didn't change post surgery. So he still had a mild hip flexion deformity. The knee graph almost came down to normal. His feet improved as well. So his foot we didn't touch except for the plano-valgus deformity. But his foot also got into less crouch. His dorsiflexion reduced. And his foot progression also improved. So you can see here his foot was completely external. The right side.
So you have done only a bony surgery.
I've done a bony surgery and a Mosca and a foot surgery. Okay. So I think you got one case to show, no? Crouch.
That's a long one.
So okay, then we stop here. I think because